My name's Nisha Joseph. I'm very happy to be here. I'm the last speaker, and I'm after lunch. So I hope everyone got a little bit of coffee. I will say, I'm a little biased, but I think this might be kind of the most exciting session because I'm talking about what's coming, which I think is so exciting. I know it's something that, for those of us who treat myeloma and run clinical trials, it's the most exciting part of our job, is being able to work on the next class of drugs, the next agent that we could offer you in clinic. So I am going to talk a little bit about CAR T, but really this is, I think you've already heard about CAR T a little bit. Okay, good. This is going to be more about new novel CAR Ts that are coming and other classes of drugs that are coming. I just want to thank HealthTree for putting this together. This might be the best advertised session I've ever been a part of. People have been asking about it for months, and thanks for coming. Two things I just want to define before I start. When I say overall response rate, do you know what that means? We're going to see that a lot. So that means how many folks had at least a 50% drop in the amount of myeloma they started with. So when we look at some of these new novel therapies, that's going to be what I'm going to be showing you. Okay, so when we think about kind of where we were and where we're going, this is a timeline, we're missing one drug actually, of all the drugs we've had since 2015. Before that, it was pretty slow. You know, Revlimid here, Velcade there. And in the last 10 years, look at how many drug approvals we've had. And actually, this year we had linvoseltamab, which is another bispecific antibody, and we're poised to have at least one more next year. So there's so much active drug development and approvals going on in myeloma. How exciting. So many more options for our patients. And not only are these drugs approved, with more time, we're learning about how to better use them. How to better manage the side effects, in which scenarios should we best be using them, can we use them, can we move them from late relapse up all the way to early relapse or even newly diagnosed to get better, can you guys hear me? Okay, to get better outcomes earlier, right? And ultimately, we're still working to cure this thing. So how do we use these novel drugs that we have in a most effective way that we can? So here are some of the things that we have and some of the things, the kind of second half of the slide is what I'm going to focus on. So you heard about bispecific antibodies today. Not only right now they're approved in late relapse, meaning 4+ lines, but they're coming and we're actively doing clinical trials at Emory in earlier lines of relapse and in combination. So right now they're approved as monotherapy, meaning by themselves, but we're looking at them in combination with IMiDs like Revlimid, in combination with proteasome inhibitors like carfilzomib. We're looking at them in maintenance. So after transplant, can we get better, longer remissions by using bispecific antibodies? We have one of these trials open at Emory currently. And even in newly diagnosed, those trials are ongoing and coming to Emory. So can we get deeper depth of response up front by using these BiTEs? CAR T-cell therapy, same thing. We now have them approved earlier lines. We're looking at novel CAR Ts that target different targets, which I'll show you. And what I'm also going to talk to you about is kind of some of these classes of drugs you might not have heard about. So one is trispecific antibodies. So you've heard about bispecific, which targets 2 things. Now we have trispecifics, which target 3 things, with the hope that it's even more effective, has better binding. Antibody drug conjugates. So this is kind of like, you can think of it as the Trojan horse type of drug. So you have an antibody and it's connected to a chemotherapy. Right? So the antibody binds to the myeloma, and then, I have a chemotherapy to deliver to you. So this is how the drug belantamab works, and there are other antibody drug conjugates in clinical trial development. And then I'm going to start talking to you about the CELMoDs. So CELMoD stands for cereblon E3 ligase modulator. CELMoDs is good. And it's essentially, you can think of them as the next class of IMiDs, right? So IMiDs is the lenalidomide, pomalidomide. So let's start talking about those. And those are the closest we have to a new approval. Okay, I'm going to skip over this. I think you've talked about it. I think the only thing I'll point out is in the anti-BCMA, we have active clinical and trial investigation. We have these clinical trials at Emory of etentamig, so another BCMA bispecific antibody in that space as well. Everything else on this slide is FDA approved. Okay, so this is a lot of medical jargon. okay? But what I want you to get from this is the way CELMoDs work, and really how IMiDs work, is they bind to something called cereblon in the myeloma cell. They lead to enhanced breakdown of these important proteins that the myeloma cell needs to live, and the myeloma cell dies. That's essentially how IMiDs work. And CELMoDs are kind of the next generation of IMiDs. They work even more potently. They bind that protein even tighter, lead to more killing of these proteins the myeloma cell needs, and more myeloma cells die. So you can think of them as more effective IMiDs with a better safety profile, which is what we want, right? So this is the ongoing initial study, the phase 1/2 study that Dr. Loniel at our institution was a big part of. The drug used to be called, let me just go back, sorry. We have two CELMoDs. One is called iberdomide or IBER, and the other one is called mezigdomide or Mezi, and you can kind of think of them like we think of lenalidomide and pomalidomide. So IBER and Mezi. Mezi is a little bit more potent than IBER, the way POM is kind of the next generation from len. Does that make sense? Okay. So when we think about this early phase clinical trial, the way they looked at it is they looked at IBER by itself, and then they had all these cohorts where they looked at IBER in combination with other anti-myeloma drugs. So I'm going to show you some of this data. So when they looked at IBER with Dex by itself, I think I have a pointer. Well, this I won't be able to see. So you can see in general, all the trials I'm going to show you are early phase trials. And what's important to understand is the patients included in these early phase trials are very heavily pre-treated, right? So to be eligible for these trials, they've had a lot of lines of therapy. And that's important to keep in mind because these are folks who are refractory to everything. So their myeloma is a little harder to treat than someone who's newly diagnosed. So you're already starting at kind of a difficult level and trying to see how these drugs work, okay? So when you look here at these three columns, these are different cohorts from the trial, but they're all IBER with some steroids. And you can see the overall response rate is around 30%. So that means about a third of patients had a 50% drop in the amount of myeloma they had. Now, does 30% seem high or low? What do you think? Okay, it might seem low. This is pretty good for this patient population. So daratumumab had the same overall response rate, and I bet a lot of people in this room has had Dara. Dara is a pretty good drug, okay? So this is in a very late relapse. The median prior lines of therapy, look there, around 5 or 6. Some people had 8 lines. They're very refractory. They're showing you there how many people are refractory to IMiDs, to proteasome inhibitors, and to Dara. So that's pretty good, 30%. What about when we combine it with other drugs, right? So they're showing you here that first column, IBER-DD says IBER-Daradex, IBER-Velcade-Dex, IBER-Kyprolis-Dex, and now we're seeing that bump up, right? Everything in myeloma looks a little better with pairs and triplets and quads. So now we have 50, 55% when you're using them in combination. Pretty good. Still a very refractory population. And what about the safety? So in general, that first row is hematologic adverse events, meaning low blood counts. We tend to just accept that. That happens a lot in myeloma patients, particularly in late relapse, and we know how to manage them. We want to focus on the non-heme adverse events. What are other side effects people have on these drugs? And that's that second row. And so that's things like fatigue, diarrhea, rash, neuropathy. And the things that are boxed in pink are the high-grade adverse events. So grade 1 and 2, when we grade events, are kind of milder things. When they're grade 3 or 4, those are more moderate, severe events that are really affecting the patient's quality of life. We want to try to minimize grade 3, 4 events, right? And if you look there, there's a lot of zeros, which is good, right? So we have a class of drugs that's pretty effective. It's not making people too sick. It works well synergistically with the other drugs we already have. Great, pretty good. The next drug, mezigdomide or Mezi, was studied in a similar fashion. So this is the CC92480. That was the name of the drug before they named it Mezi. Again, looking at Mezi in combination with steroids in a heavily pretreated population. And how did this look? So again, those bar graphs, you see the ORR at the top, right? Overall response rate, the first column there is all patients, so 40%. The second one is patients with plasmacytoma. So this is myeloma growing outside of the bone. The reason this matters is when myeloma starts growing in other places, that is signaling a smarter myeloma. It shouldn't do that. It should stay in the bone. So when it starts growing other places, that's a little smarter, and that translates to us as a little harder to treat. And even in those patients, we're seeing a pretty good response rate, so 30%. And then patients with prior anti-BCMA. So that's, again, even more heavily pretreated person because they've had a bispecific antibody or maybe CAR T, and you can see there the overall response rate is 50%. Okay, so those are good numbers in such a heavily pretreated population, and again, relatively well tolerated. I didn't have it here. Mezi, the main thing there is cytopenias. So you have to be real careful about what you're pairing it with. Cytopenias, means low blood counts, okay? There's a lot of ongoing investigation with both IBER and Mezi, and we have many of these trials at Emory if you're interested. This first one is called the Excalibur Maintenance Trial, and this is looking, you can look at this stage 2, which is where the trial is now. This is looking at maintenance post-transplant. So currently standard of care for standard risk patients after transplant is lenalidomide or Revlimid until progression. There's some caveats in there, but that's what we tend to do. So what this trial is doing is randomizing patients 1-to-1 to either getting Revlimid until progression or IBER until progression. So you're either getting what we already were gonna do or potentially the new standard of care, and let's see what happens. Okay, so we have this currently at Emory. If anyone is in early stages of their course and wanna talk about this trial, we're actively enrolling it. We also had the Excalibur relapse refractory trial. This is now closed, but we did enroll several folks on this trial. And this was in early relapse, looking at IBER in combination with DARA. It's again a randomized study, so IBER DARA versus DARA Velcade until progression. And then there are ongoing studies with Mezi. We don't have this one, but we have this one, Successor 2. This is currently open. We have a few slots left. This is, again, early relapse. This is looking at Mezi in combination with carfilzomib, or Kyprolis. So a lot of ongoing research with IBER and Mezi, and hopefully at least one of these drugs will be available in the near future for us to use in the clinic, even off trial. Questions about that? Okay. Oh, I'm sorry, don't ask me questions now. Okay. CELMoDs, so that's the first class of drugs, CELMoDs, IBER and Mezi. So next I want to talk to you about a class that doesn't really yet have a name, but this is almost like a next generation from CELMoDs. We kind of colloquially say a super IMiD, and the name of this drug is Cemsidomide or Cemsi, C-E-M-S-I, Cemsi. Again, a lot of medical words. It again is involved in cereblon binding and is even more potently binding and leads to high myeloma cell death, okay? I'm only showing you this study schema so you see how we do these studies. This is called a dose escalation, where we start at really low doses and go up. And this is how we look at drugs when we're first trying to figure out how to best dose them. We don't want to cause harm, so we start at low doses, and then if people do okay, we go up. Right? So when I start showing you the responses, you're going to be seeing responses at each of these dose levels. Some of them weren't that active, but we had to start there to see. In general, in the green boxes, you can see, just like the other trials I showed you, these are very heavily pretreated patients. So 75% had prior CAR T or T-cell engager. That just means a bispecific. 29% had both. 75% had some kind of prior BCMA, and 80% of patients were pentaclass exposed, meaning they've seen both IMiDs, both PIs, and DARA, for the most part, DARA or ESA. In general, again, if you look at 3, 4, and 5, we're not seeing a lot of grade 3 or 4 events outside of infections, which in general, unfortunately, we see, particularly in relapsed myeloma, you're a little more prone to infection, but overall, this drug was pretty well tolerated. So let's look at how it performed, right? Overall response rate. So if you look kind of all the way over to the right where we're at the higher doses, right? We had to go up with dose. Some of the lower doses, we didn't see as much activity. But once we start getting to 75 and 100, those are pretty good numbers, 40%, 50%, heavily pretreated patients. Total was 34%, but that's taking all the doses, right? But this is a pretty effective drug, and this is alone, and I just want to point out all these drugs I've talked about are oral. So these are pills that people are taking at home, coming in once a month, probably a little bit more because it's a phase 1 trial, but ultimately that's the idea. So I'm going to kind of have these slides throughout just to kind of tell you what we're doing at Emory. We had the phase 1 first-in-human trial open here at Emory. We enrolled a lot of patients on it. It's now closed, but we're about to open a combo trial with Cemsi and a bispecific antibody, hopefully in early 26. So a lot of exciting ongoing research with Cemsi as well. Okay, so now I'm going to shift gears and talk a little bit about one CAR T-cell product, and this is called Arlo-cel. The BMS with numbers is kind of what it used to be called. We call it Arlo-cel. So what's different about this CAR T-cell product compared to the ones that are FDA approved is what it targets. So the two CAR T-cell products we currently have target something called BCMA, which I'm sure we've already talked about, stands for B-cell maturation antigen. This targets something called GPRC5D, which is what talquetamab targets, talc, that other bite. So this is a different antigen than BCMA. Why does that matter? Once someone has BCMA therapy, they're not going to respond. They're less likely to respond to a BCMA drug next. So this is more options. Someone who's had a BCMA CAR T or is coming off of a BCMA bite, we have the option of giving them a really effective therapy potentially that targets something else. They're more likely to respond. Does that make sense? Okay, so if you look here, again, very effective. So they looked at this in multiple different doses as well. The overall response rate for all the different doses was 88%. At 150 million, which is not the dose they're actually going to move forward with, but it was 91%. And then when you look at folks who had prior BCMA, meaning they had a CAR T or a bispecific antibody that targeted BCMA, 100% of those people responded. Pretty impressive. Not a lot of patients. I'm going to caveat there. If you look at the N, that means number of patients. It was only 8 patients, but still pretty impressive, right? This is an effective drug. It's showing you in that table how many folks had prior BCMA, how many folks had extramedullary disease. Those are those plasmacytomas outside of the bone, high-risk cytogenetics, triple-class refractory. So what they're trying to tell you is these are folks who've seen a lot of drug and they still had a good response. Oh, and the last thing I'll say there is at the very bottom under the table, 86% of patients who were able to get MRD, which is, have we talked about this yet today? A little bit. MRD is essentially the most sensitive test we have on the bone marrow. So if that's negative, the person's in a deep remission. 86% of folks were MRD negative. Okay, so effective drug and heavily pretreated population. Overall, with CAR T-cell therapy, we're looking at how many folks have CRS, how many people have neurotoxicity and infection. In general, kind of on par with what we've seen. Anytime you target GPRC5D, we worry about those weird side effects you've heard about with talc, which are changes in taste, hair, skin, nail changes, and they're not seeing a ton of that. We see some of it, but not a ton and no high grade. So overall, pretty well tolerated. Definitely not the rates of dysgeusia or weird taste that we see with talc. And I think one of the differences is talc, we're giving continuously. This, we're targeting GPRC5D for a select period of time, and then we're done. So it's a little different. So we currently have 2 trials looking at Arlo-cel at Emory. We have the phase 2 trial, which is looking at Arlo-cel in late relapse, meaning folks who've had at least 3 prior lines of therapy. And we also have an ongoing phase 3 study. Phase 3 means it's randomized to kind of the new standard versus the old standard. And so that's an earlier relapse, so folks who have had 1 to 3 prior lines of therapy, and you're randomized to either getting Arlo-cel or getting a standard regimen like Daracardex or Kyprolis or something like that. Okay, now we're going to talk a little bit about the trispecifics. So this is a trispecific made by Janssen, and this was results that were recently presented, I believe at ASCO. So the way these trispecifics work is just like bispecifics, they target different things, but now we're targeting 2 things on the surface of myeloma and 1 thing on the surface of the T cell or the immune cell. So it's targeting CD3, which is expressed on the surface of the T cell. That's the immune cell that needs to kill the myeloma cell. And it's also expressing BCMA and GPRC5D. Why does that matter? Sometimes when people have been treated with BCMA, they no longer express BCMA. Same with GPRC5D, they might not express GPRC5D. Even if they haven't been treated, they have variable expression. Now you have a backup. You have BCMA, if you're not expressing, if that myeloma cell isn't expressing BCMA, you have GPRC5D, right? So it's gonna get more myeloma cells, less myeloma is gonna kind of escape, for lack of a better word. This was looked at in this early trial in folks who have had prior BCMA and prior GPRC5D, and in general, again, that second red box is they've seen it all. They've seen PIs, IMiDs, pentadrug exposed, they've seen a lot of drugs. All right, so look at let's start with the first column, which is folks who've had either BCMA or GPRC5D. Overall response rate is 55%. The caveat there is that's ranging across a lot of different dose levels. When you look at folks at higher dose levels who were not exposed to BCMA or GPRC5D, which is the next set of columns, in red there at 100 milligrams every 4 weeks, overall response rate is 100%. And then 100% in a slightly higher dose as well, but at 100 milligrams every month, monthly dosing of a drug, 100% of folks are responding. Pretty good. In general, again, if you look at CRS, it's around 50%. That's kind of what we see with bispecifics, a little higher with bispecifics. When we're looking for those GPRC5D side effects that we worry about, like taste and nail and skin, about 50% of patients are having those, but they're all early grade. We're not seeing a lot of grade 3, 4. Okay, that's not to say it doesn't matter, but usually it's easier to manage when it's a lower grade. So we will have this trispecific antibody available in early 2026. We'll also have a randomized study in earlier relapse with the same trispecific, and Dr. Shaw will have another trispecific, hopefully in the next month or so, that instead of GPRC5D, it targets CD38, which is what daratumumab and isatuximab target. So a lot of exciting things, and we'll have these options for those of you who might be eligible in our clinics. Okay, and then lastly, I want to talk about a drug called enobrotib. So this works completely differently than any drugs we currently have on the market. This is something called a P300 inhibitor. It also works on this same cereblon pathway and makes the myeloma cell more prone to dying. It works best in combination with other drugs, specifically IMiDs. So this was an early phase trial looking at enobrotib or Eno in combination with the drug called pomalidomide or POM, which is an IMiD. So they're showing you in these plots kind of how folks have responded over time. If you look at the bar graph kind of in the middle there, you can see that at these different dose levels, we're having overall response rates between kind of 60 and 80%, okay? And that's in combination, that's different than monotherapy or by themselves, but that's still pretty good. And this is, again, a heavily pretreated population. So across all cohorts, you can see that overall response rate is 49% at the highest dose level. So at the highest dose, we were able to go, but patients were still able to tolerate it. The overall response rate is 75%. Okay, pretty good. Duration of response around 10 months. Again, please remember this is a late relapse since the first time we're looking at the drug. Okay, so don't get too hung up on those numbers. In general, these are combinations that work and deserve more attention, more clinical trial development. The safety issues that we see with Eno are a little different. There's a good amount of thrombocytopenia, so you have to be very mindful of that because the IMiDs can have thrombocytopenia, and that means low platelets. So if the platelets get too low, the main side effect is bleeding. The other thing we see with Eno is fever. That's what pyrexia is there in the middle. We don't really know why. It doesn't tend to cause big issues, except for we have to admit the patient, work them up. It usually goes away after the person gets used to the drug. We also see fatigue. And we also see low sodium levels. Sometimes they get better once the myeloma starts going away. So we had that study, that was phase 1. We had the follow-up phase 2 study at Emory. We're gonna have another Eno-PomDex study available next year, and they're working on a cohort that looks at with a bispecific antibody, so either Elra or teclistamab. So a lot more coming there as well. And then Dr. Nuka has another study looking at a different P300 inhibitor that's still in dose escalation. But this is another kind of ongoing area that you'll probably see more drug development, more updates and data from in the next few years. Okay. I show this. This is our current clinical trials portfolio at Emory. I mostly show this just to show you how hard we're working on this and how many options you have. Many of these trials that I mentioned, I've already mentioned. We have a CAR T-cell therapy ongoing that Jonathan Kaufman at our institution is running, looking at CAR T in AL amyloidosis, which is exciting. We're looking at anti-BCMA CAR T, a different product called Anito-cel, which has a different safety profile than cilta-cel in early lines. Currently enrolling. We have multiple trials looking at treatment in smoldering myeloma that are currently enrolling, and we have several post-transplant maintenance studies, in addition to all these relapse studies, many of which I've talked about. And importantly, there's a lot of trials that we have that are in the pipeline, meaning we're just working to open them right now. So this isn't even exhaustive, actually. There's several others that we're working to open. So we have a lot more things that'll likely be open at Emory next year, if not later this year. We have a CAR T-cell therapy that Dr. Nuka's leading that targets 2 different targets, just like bispecific, but now this is a CAR T-cell therapy. Trispecifics we've talked about. We're looking at bispecifics in combination and different lines. And we have a lot of studies coming looking at belantamab as well, in addition to an ongoing belantamab study in maintenance right now. So a lot of work, and I'm just showing you this to just show you how exciting it is, how many options we have, and how rapidly things are changing. Okay, and with that I'll conclude. Thank you very much for your time.